Welcome back, guys. Now let's continue with the topic of proximal convoluted tubule. Okay, after the Bowman's capsule, the next part of the nephron is proximal convoluted tubule. Now see, what are the important points that you should know regarding the proximal convoluted tubule? See, PCT is highly active segment of the nephron. PCT is highly active segment of nephron. So in the entire nephron, the most active part is the PCT. Why we are saying? Because in the PCT, say, most of the substances are reabsorbed. Maximum reabsorption occurs where? In the PCT. Maximum reabsorption. Maximum reabsorption of substances occurs in the PCT. Most of the substances are maximally reabsorbed in the PCT, except one, except magnesium. Other than magnesium, all other substances are maximally reabsorbed in the PCT. Okay. Next, you will be having a doubt. So then, where magnesium will be reabsorbed? Magnesium will be reabsorbed in the thick ascending limb of loop of Henle, thick part of ascending limb of loop of Henle. Done. Next, any other specialty regarding the PCT? PCT cells. Okay, in the PCT, there will be brush border epithelium. Brush border epithelium. Why brush border epithelium? Because brush border epithelium helps in increasing surface area. Surface area for reabsorption. Okay, increase the surface area for reabsorption. Done. Now, let's see what are the substances reabsorbed in the PCT. Okay, what are all the substances? I have told you maximum reabsorption of substances happening. What are all the substances reabsorbed in the PCT? First, number one, sodium chloride. How much sodium will be reabsorbed? 70% sodium will be reabsorbed and 70% chloride will be reabsorbed. Both 70% let's say. Actually, chloride is little less, but anyway. Sodium, chloride, 70. Actually, chloride is somewhere around 65. But let's, for understanding purpose, let's say 70. Next, water. How much water will be reabsorbed? Same 70% water will be reabsorbed. So 70% sodium reabsorption, so 70% water reabsorption. Wherever sodium goes, water follows. Next, bicarbonates, HCO3 minus. How much bicarbonates are reabsorbed? Almost 80% of the bicarbonates will be reabsorbed. Next, glucose and amino acids. I have told you already, both glucose and amino acids, they are freely filtered substances, but they are 100% reabsorbed in the initial part of the PCT itself. See, PCT is having like some parts, like convoluted part, straight part. So in the initial part of the PCT itself, in the starting of the PCT itself, 100% amino acids, 100% glucose will be reabsorbed. Okay, so this is the MCQ. 100% amino acids and 100% glucose is reabsorbed in initial segment of PCT. The starting part itself, it will be reabsorbed. Next, what else you should know clinically here? Let's say, guys, here is the Bowman's capsule I am showing you, and down to the Bowman's capsule, what is the structure that I am drawing? Here is the PCT, proximally convoluted tubule. Convolutions are there. Now, there are different transporters. See, there is a transporter for glucose reabsorption, amino acid reabsorption, sodium reabsorption, chloride reabsorption, bicarbonate reabsorption, phosphate reabsorption. There are different transporters which are helping in reabsorption of all different substances. There is a condition where these transporters are not working. Okay, in this condition, what exactly is happening, guys? There is a condition where all the transporter in the PCT are not working. So I can write global defect in PCT transporters. Global defect in PCT transporters. So there is entire defect, there is entire PCT defect. So now tell me, do you think water is reabsorbed? No. Polyuria, glucose urea, amino acid urea, bicarbonate urea, kaliuresis, all are lost. Everything is getting lost. So this condition is called as, means global defect in PCT transporter. The name of this condition is called as Fanconi. Okay, syndrome. Okay, Fanconi syndrome. Don't confuse it with Fanconi's anemia. That is different. Fanconi's anemia is different. Fanconi syndrome is different. Fanconi syndrome is a defect in the PCT. Done. Next, before going further, okay, how water reabsorption occurs in the PCT. Let me give you some basic understanding about the osmolarity. Now let's imagine there is a beaker, guys. Here I am showing you a beaker with water, some water. Now imagine I am keeping pure water. First of all, I am keeping pure water. If I am having pure water, what is the osmolarity? The osmolarity of the pure water is always 0. Pure water doesn't have any osmolarity. There is no property of osmolarity for the pure water, 0. Now, if I add some salts into it, if I add some ions like sodium chloride into it, what will happen to the osmolarity? See, if I am adding some salts into it like sodium chloride, magnesium, the osmolarity increases, means now say it is becoming 10 milliosmol. So what is the concept? The concept is only water, no osmolarity. If you have some ions in it, there will be some osmolarity value to it. Okay, so more the number of ions, or you can say more the solutes, more will be the osmolarity. For example, now I am adding even more sodium chloride here. What do you think will happen to the osmolarity value? From 10 it will become 100, from 100 it may become 1000 also. So more the number of ions, more osmolarity. Less the number of ions, less will be the osmolarity. Understood? Next step, if I am adding only water to it, say let's say here there is a beaker with the water of 10 milliosmoles, or let's say 100 milliosmoles. Okay, let me write here. I am taking now example of 100 milliosmoles. This solution is having the osmolarity of 100 milliosmoles. Now I am adding pure water to it. Means now adding, see what's the water? I am adding water molecules. Now I add only water molecules. Now what do you think will happen to the osmolarity? Now osmolarity will decrease because the ion concentration will decrease, right? Okay, so if you add only water, more the water, what will happen to the osmolarity? Osmolarity decreases. More the ions, osmolarity increases. Done? Clear. Now the final rule, the most important. Now see, I am taking a beaker. And what is the osmolarity of this beaker? The osmolarity of this beaker is, let's say 100. Again 100 I am taking. Now I am taking a small glass. Okay, let's say I am taking a glass, guys. Okay, I am taking a small glass. Now with this glass, I am taking water out of it. I am removing some, I should say the word fluid, means by dipping, means I am taking a glass. I am dipping this glass into the beaker and I am removing some fluid out of it. So I have removed some fluid. What I have removed? I have removed fluid. See, I am not using the word water, I have removed the fluid, which means I have removed some water, also some solutes. Now tell me, what do you think will happen to the osmolarity? Sir, here osmolarity will still be 100 and the water, whatever is there here, the fluid, whatever is there over here, its osmolarity is also 100. Okay, try to understand. Imagine, now I am taking this bottle, imagine it's like a Coca-Cola. Okay, imagine it's like a Coca-Cola. Now, what will happen? See, if I drop some of this water, if I drop some of this Coca-Cola into some glass, do you think will there be any change in osmolarity here? No, the taste will be still the same, and the taste of the cola that I have taken in the glass, it will be also still the same, because you have removed the solutes as well as the solvents in same proportion. See, the point is when you remove the solute as well as the solvent, that is water as well as the solutes in same proportion, the osmolarity will not change. You understood? So the cola example, again I am giving the cola example. See it, imagine a Coca-Cola bottle. Okay, so you dip, you remove some of the cola into a glass. So will there be any change in taste? No. Whatever the cola which is there in the glass and whatever the cola which is there in the bottle, it will be still the same osmolarity, same concentration, same taste. There won't be any change. Okay. So yes, right. If you remove solutes and solvent in same proportion, osmolarity is unchanged. Done. Now, by using this logic, I want you to answer what happens. Okay. First thing, sir, what is your plasma osmolarity? Guys, try to understand here. First question number 1. Okay. See, here is your blood vessel. Let's say glomerular capillary. This is your glomerular capillary, guys. Now, who is there in the glomerular capillary? There will be plasma. Okay. And what is the plasma osmolarity? See, your plasma is not a pure water, right? It's having sodium, potassium, chloride, magnesium, lot of proteins are there. So definitely because of these ions, because of the solutes, there will be some osmolarity. And how much is that value? 300 milliosmoles. Okay, 300 milliosmoles. The plasma osmolarity 300 milliosmoles. Now, here is the Bowman's capsule. Okay, here is the Bowman's capsule and down to it what is there? PCT. Now it is the same plasma which is getting filtered, right? So what is the osmolarity here? same 300 milliosmoles. Whatever the urine that is getting filtered, the urine osmolarity is also same 300. Okay, it's because it's exact plasma that is getting filtered, 300, 300. Now, in the proximal convoluted tubule, I have told you how much water will be reabsorbed. 70% of the water will be reabsorbed. 70%, I am removing the water. 70% means I am removing the water. Now, my question to you, what do you think will happen to the urine? The urine here will be concentrated, or the urine will become diluted. You are removing water, no? So, what will happen to the urine osmolarity? Is it getting concentrated, or the urine osmolarity increases or decreases? Now, most of the students will think, sir, we are removing water, right? So, urine here will become concentrated. But the answer is no. Urine osmolarity will still be here, same 300. Why? Because how much sodium chloride will be reabsorbed? 70% solutes, that is sodium chloride. So, what I am trying to say, 70% solute as well as 70% solvent. Both solutes and solvent, that's water as well as ions, they are reabsorbed in same proportion. Okay. So, what will be the osmolarity here? The osmolarity will be still 300. Okay. So, now tell me, in the PCT, urine is getting concentrated or diluted? Neither concentrated nor diluted. It is isotonic to, it is exactly isotonic. Isotonic to what? Plasma, exactly equal to plasma. So, that is the first MCQ, guys. Okay. So, urine in the PCT, it is isotonic to plasma, that is same 300 milliosmoles. I have told you, wherever sodium chloride goes, water follows. There is no need of any hormone. So, such type of water reabsorption called as, see, water reabsorption in PCT is not under any hormonal control, no need of any hormones. So, such type of water reabsorption is called as obligatory water reabsorption. Okay, obligatory water reabsorption. Obligatory means what? Obligatory means must and should. It's a 70% water should be reabsorbed because 70% chloride is getting reabsorbed. Okay, is there any need of antidiuretic hormone? No, no need of antidiuretic hormone. Okay, no need of antidiuretic hormone for the water reabsorption here in the PCT. Okay, so that's why obligatory water reabsorption. Done. Next MCQ, how the glucose and amino acids are getting reabsorbed in the PCT. Now, first of all, when you look at this diagram, what is the immediate thing that is coming? See, you can see the brush border. So, definitely this is PCT, sir, because there is brush border, this is PCT. Now, this is the side of the urine going, this is the side of the lumen. First, you can write here, this is the side where urine is going, lumen of the nephron. Okay, lumen part of the nephron, urine is going. Now, in the urine, who is there? Right now, the important substances like glucose and amino acids are present. So, these green color molecules which I am highlighting, these are your glucose molecules. So, tell me, we have to reabsorb this glucose, yes or no? Yes, we have to reabsorb this glucose. So, yes, with the help of this transporter, which I am showing here in the blue color, yes, see, glucose is getting reabsorbed. But along with the glucose, see, along with the glucose, who else is going? Sodium is also going. So, now tell me, the glucose reabsorption occurs along with which ions? The glucose reabsorption occurs along with sodium ions. So, now this transporter is called as sodium glucose linked transporter. So, the glucose reabsorption is linked with the sodium reabsorption. So, the name of this transport is called as SGLT type 2. Okay, SGLT type 2, because SGLT type 1 is present in the intestines. But in the kidney, in the PCT of the kidney, there is SGLT type 2. Okay. Now, question is, when two substances are going together, can I call it as a co-transport or symport? Yes, two substances are going together in the same direction. I have told you, when two substances are getting transported in the same direction or the opposite direction, doesn't matter. When two substances are getting transported, always it's an example of what type of transport? Active transport, that too secondary active transport. Have I told you? The mnemonic, all gluts are examples of facilitated diffusion. All gluts, all GLUTs, gluts. The mnemonic I gave you is GF, girlfriend. Okay, all gluts are examples of facilitated diffusion. All ATPases, pumps are examples of primary active transport. All co-transporters, symporters, antiporters, they are all examples of what? They are all examples of secondary active transport. So, now you tell me, this glucose reabsorption. Glucose reabsorption is an example of secondary active transport. Okay, fine. Now, you tell me, do you want the glucose to be present? Do you want this glucose to be present in the cell? Or do you want this glucose to go into the blood? We want it to go into the blood, right? What is the point of having the glucose in the kidney? Okay, so now we have to transport this glucose into the blood. For that, there is a different transporter. The name of this transporter is called as GLUT2. So, right here, GLUT2. So, with the help of this GLUT2, The glucose is going into the blood. So wherever you see the word glut, all gluts are examples of what? Facilitated diffusion. Okay. Now from this, can I say something like this? Entry into the cell with the help of SGLT2. Exit out of the cell is with the help of GLUT2. SGLT2, GLUT2. Entry is an example of secondary active transport. Exit is an example of facilitated diffusion. On the luminal membrane or the apical membrane, which transporter is there? There is SGLT2. On the basolateral membrane, this membrane is called as a basolateral side. So basolateral membrane, there is GLUT2. Luminal membrane, SGLT2. Basolateral membrane, there is GLUT2. Done? Now my question to you. See, if you can block this transporter, today what am I doing? I am blocking this transporter. If I block this transporter, what do you think will happen? If I block this transporter, do you think glucose can go into the cell? No, glucose cannot go into the cell. So what happened to the glucose reabsorption? Decreased. So what will happen to the blood glucose levels? Decreases. So tell me, in which people we can use these drugs which can actually decrease the blood glucose levels? In the treatment of diabetes. So if you can block this transporter, the glucose reabsorption decreases. So tell me, whenever the glucose reabsorption decreases, the blood glucose levels can go down. So right, there are drugs called as SGLT2 inhibitors. What are the examples of SGLT2 inhibitors? Canagliflozin, dapagliflozin, empagliflozin, okay, these drugs, anything which ends with the word gliflozins. Okay, canagliflozin, dapagliflozin, empagliflozin, this gliflozin group of drugs, what they are? They are SGLT2 inhibitors. So they will cause the glucose urea. Okay, what they will do? They will cause the glucose urea, glucose lost in the urine. So now right, what they will do? SGLT2 inhibitors, important points, they are used in the treatment of type 2 diabetes mellitus, especially they are used in the type 2 diabetes mellitus, they will cause glucose urea. But the problem with these drugs is, see where the glucose is going today. Now the glucose is unnecessarily going to the urine. No, the glucose is going to the urine. So this glucose can act as a medium for the growth of bacteria, can lead to urinary tract infections. So the problem with this SGLT2 inhibitors is, right, the side effect is the glucose can cause the infections in the urine. So that is urinary tract infections, UTIs. So this is the important MCQ that I want you to know. So done. So with this, what we have completed? We have completed how glucose reabsorption occurs. Glucose reabsorption occurs along with sodium with the help of SGLT2 transporter. SGLT2 transporters are examples of secondary active transport. GLUTs are examples of facilitated diffusion. SGLT2 inhibitors are used in the treatment of diabetes mellitus type 2. The problem with them is glucose urea and urinary tract infections. Okay. So finally, it's not only the glucose but amino acids also reabsorb along with sodium. So glucose reabsorption and amino acid reabsorption occurs along with sodium. Both are examples of what? Both are examples of secondary active transport. With this, glucose reabsorption in PCT topic also completed. In the next part of the PCT, we will be discussing about how glucose excretion will occur. Okay, why glucose excretion will occur? What is the transport maximum value for glucose? What is the renal threshold value for glucose? Okay, and let's see those glucose curves. Okay, hope the video is helpful. Thank you.